Today, we're diving into something we all see in the clinic, right? That patient who comes in and says, "Doc, I just can't take my statin." We're going to build a practical guide to get you from that initial complaint to a really confident diagnosis.
So, here's our game plan. We're going to start with just how big the adherence problem really is. Then we'll nail down what statin intolerance actually means according to the latest guidelines. We'll play detective and look for other causes, walk through super practical 4-part evaluation, and then finally we'll talk about how to lock in that diagnosis.
First things first, let's just set the stage for why this is such a huge deal. This isn't some rare niche issue. This is a massive barrier to preventing heart attacks and strokes, and it's happening in our exam rooms every single day. Look at that number. Seriously, up to 60%. That means within just 2 years, more than half of our patients have stopped taking their statin. And this isn't just about medication lists being out of date. This has a real, direct, and frankly scary impact on cardiovascular events. So what's feeding this beast? Well, this quote really hits the nail on the head. It's the noise from media, from social media, and it all contributes to what we call the nocebo effect. You've heard of the placebo effect, right? Well, this is its evil twin. The simple expectation that a drug will cause harm can actually make a person feel those symptoms. All right, so to cut through all that noise and those vague complaints, we need a really clear, precise definition. We need an objective standard to work with, and luckily, we've got a new framework that does just that. And here it is. This is the official 2022 definition from the National Lipid Association. And it gives us 2 absolutely critical guardrails. First, the symptoms have to get better when you lower the dose or stop the drug. That's non-negotiable. And second, you really can't slap on the intolerant label until you've given at least 2 different statins a fair shot. It stops us from giving up way too early. Now, this brings us to a really important fork in the road. We have to figure out if we're dealing with partial intolerance or complete intolerance. You see, the question isn't just, can my patient take this statin? The real question is, can they tolerate any statin at any dose? Because the answer completely changes our entire management plan.
So before we point the finger at the statin, we have to put on our detective hats. It's just good clinical practice, right? We have to do our due diligence and hunt for other things that could be causing or at least worsening our patient's symptoms.
Just think of this as your differential diagnosis map. It's so easy for our brains to jump straight to the statin when a patient says muscle aches, but this reminds us to zoom out. Could it be their thyroid? Is there a new medication they're on that's interacting? Maybe a lifestyle thing. We have to look at the whole patient.
Okay, let's zero in on some of the usual suspects here. You absolutely have to check their med list for interactions, especially things that inhibit CYP3A4. And you've got to run the labs. Is there TSH creeping up? Is there vitamin D in the tank? These are super common things that cause muscle aches, and they are so easy to fix. All right, this brings us to the real meat of our explainer today. We're talking about a systematic 4-part approach for what to do when that patient is sitting in front of you complaining about their statin. This flowchart right here, this is your clinical roadmap. It's the core of everything we're talking about. A patient reports a side effect. Our job is to figure out which of these 4 lanes they belong in, because trust me, each one leads to a totally different destination. Let's break them down. So first up, category 1, the symptoms have absolutely nothing to do with the statin. Maybe they just overdid it at the gym, or, and this is a big one, it could be that powerful nocebo effect we talked about, where just the fear of a side effect becomes a self-fulfilling prophecy. Okay, scenario number 2 is that there's a reversible cause, one of those things we just investigated. Maybe they started an antifungal for a toenail infection, and boom, now their statin level is effectively higher and causing problems. That's a solvable issue. Third, and this is probably the category you'll see the most, is partial intolerance. And honestly, this is great news. It means your patient isn't intolerant to statins as a class. They're just intolerant to a specific statin at a specific dose. This is a problem we have a ton of options for. And last, we have our 4th and by far rarest scenario, complete intolerance. This is the patient who, after you've tried different statins and different strategies, truly cannot tolerate any of them. For this small group, non-statin therapies really become our main focus. Okay, so we've got our 4 potential buckets. How do we actually confirm which one our patient falls into? Let's walk through the final steps that get us from just a suspicion to a rock-solid diagnosis. The gold standard here is a pretty simple process. A D-challenge followed by a re-challenge. Step 1, you stop the statin. Give it about a month or so and see if the symptoms go away. Step 2, if they do, you re-challenge. But you go back in smarter, maybe a different statin or a much lower dose. Step 3 is just to assess. If the symptoms come back, you've pretty much confirmed the link.
And here is the key piece of information that should give you and your patient a ton of confidence. The evidence is just overwhelming. This study found that the vast majority of patients who stop a statin because of side effects can successfully tolerate one when they're properly rechallenged. That is a powerful fact to share. Now, if you've got a really complex case or you just want to add another layer of objectivity to your workup, you can use a validated tool. The SAMS CII is a great one. It's basically a scoring system that looks at the pattern of symptoms and helps you quantify the probability that the statin is the actual cause. So let's wrap this all up with the big question on the screen. The real key here is a shift in our mindset. If we can move away from just using this simple and kind of unhelpful label of intolerant and instead adopt this structured diagnostic approach, well, we can break that frustrating cycle of starting and stopping. We can solve this puzzle for most of our patients and, most importantly, keep them on the therapy that could literally save their life.